क्या हुआ? फोन कीजिए ना उसको, नहीं उठा रहा है। फोन नहीं उठा रहा है। अनम्यूट कीजिए टीपी, अनम्यूट कीजिए अपने को।
सर वो ये वेटिंग फॉर 8 o'clock
है
ज्वाइन कर रहे हैं सर। Actually, he is in misconception that last class he has taken. I said कि 8 o'clock.
नहीं नहीं नहीं, 8 o'clock का लिया था वो।
कभी कभी हुआ ही नहीं है, उनको पता नहीं। और उसमें जस्ट इसके पहले भी हमने फोन किया तो ही सेड 2-3 मिनट में ज्वाइन करते हैं। लगता है बिजी है, बट ही सेड ज्वाइनिंग।
योगा वाला प्रचारित करते रहिए।
सर योगा वाले में जैसे इसमें बनाते हैं ना, बनाए थे ना सर, उस तरह से आप अपना जैसे करते हुए, और डॉक्टर इनको एक एक गुप्ता को और वो जो है ये है उस तीनों का ईद डालते हुए तब करिएगा तो ज्वाइन करेगा सर। ऐसे ही कर दीजिए। आप ज्वाइन शुरुआत ही करवा दीजिए, इसके बाद तब यह हटिएगा सर। जैसे जैसे इस समय करते हैं उस तरह से करवा दीजिए सर।
ना ठीक करा देंगे, करा देंगे।
हाँ, जुवेंटस के द्वारा ही कराएंगे ना?
ना ना, नहीं करेंगे। बड़ा हल्ला किया था उसने।
अच्छा।
बहुत हल्ला करा था उसको। नॉइज पोल्यूशन बहुत है।
नहीं तो जैसे इसमें हम लोग कर रहे हैं इस क्लास में, दैट
हाँ
भी दिस योगा क्लासेज विल बी आल्सो लाइक दैट।
हाँ, शांति से हो।
हाँ हाँ।
कितना कितना हल्ला हो रहा था उस दिन।
बहुत बहुत हल्ला हो रहा था।
तो इस पर तो अभी बातें नहीं किए हैं। अच्छा, आज करेंगे।
नहीं नहीं, वो जो है ना, आप अपना क्या, ये तो मधुकर। सब लोग वेट कर रहे हैं। हाँ सर। जस्ट ज्वाइनिंग सर।
ठीक 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 ठीक।
जी सर, जी सर। एक एक गुप्ता सर कुछ बोलेंगे और उसके बाद वो योगा टीचर्स करवाएंगे, वो इसी तरह से उसमें भी करवा दीजिए सर।
ठीक ठीक ठीक।
इंट्रो इंट्रो करेंगे और योगा टीचर अपना करेंगे, करवाएंगे। क्योंकि अब दोनों को मिलवा दिए हैं सर, एंड दे हैव गॉट 1 hour डिस्कशन कि क्या करना है 6 क्लास में। जी सर। और वो भी जो है वहाँ ये है, टीचर भी रहे हैं सर, डॉक्टर ए के गुप्ता।
कहाँ?
वही मुंगेर वाले योगाश्रम में।
उनका व्हाट्सएप
गुड
नंबर।
इवनिंग सर।
हाँ यस।
हाय सर, गुड इवनिंग सर।
गुड इवनिंग, गुड इवनिंग टू बी
सॉरी
जी।
सर, सॉरी सर,
गुड
सॉरी।
इवनिंग मधुकर।
गुड इवनिंग सर।
गुड इवनिंग। चलिए स्टार्ट कीजिए
नाउ
सर।
स्पीकर डॉक्टर मधुकर हैज अराइव्ड। it is a bit late, so I will request Dr. D.P. Singh to ask Madhukar to start the session as early as possible. Dr. D.P.
Yes,
Singh, please.
sir. Respected Professor Dr. Kamlesh Tiwari, sir, our Revered Dean, Indian College of Physicians, who has initiated this historic initiation of short certificate course on different subjects of medicine, including the respiratory diseases. And today we are privileged to have Dr. S.K. Madhukar, a renowned pulmonologist, delivering a master class on optimizing NIV, non-invasive ventilation. Dr. Madhukar's expertise in respiratory medicine is well established, and his insights on NIV will undoubtedly be very valuable to each one of us. NIV, as you know, is a critical component in the management of respiratory failure, and optimizing its use can significantly impact potential patients' outcome. Dr. Madhukar will share his knowledge on the latest strategy and best practices for NIV, covering topics such as patient selection, interface selection, ventilation modes, and troubleshooting. And for this ICU setting, especially the respiratory diseases, this is very, very valuable. Please join me in welcoming Dr. S.K. Madhukar to the forum, and I'm confident that his presentation will provide us with practical tips and pearls to enhance our understanding and application of NIV in clinical medicine. Just we have enriched knowledge in approach to ABG, so will be in NIV. Thank you. Over to Dr. Madhukar.
Thank you so much, Dr. D.P. Singh, sir, for your kind introduction.
अनम्यूट करो.
Thank you, Dr. D.P. Singh, sir, for such a kind introduction. It's always a pleasure to be on the platform which is shared by you. Honorable Dr. Kamlesh Tiwari, sir, my teacher and mentor. Dr. Sanjay, sir, my mentor. Today, as Dr. D.P. Singh, sir, said that we'll be talking about NIV. And sir, is my slide visible?
Yes, okay.
Okay.
But full view, make it full view. Slides.
Is it okay, sir?
Okay.
Yes, okay.
Yeah. So we'll be talking about optimizing non-invasive ventilation in clinical practice. NIV, as we all know, is the mainstay to treat a patient who need augmentation of the ventilation, whether it's an acute respiratory failure or whether it's a chronic respiratory failure. NIV is the most common mode of ventilation in both acute respiratory failure and chronic respiratory failure globally. But unfortunately, despite being such a common mode, the NIV failure rate in India stands somewhere between 30 to 40%. This is because we somewhere lack in optimizing the non-invasive ventilation in the patients with respiratory failure. Not surprisingly, because we lack training about NIV in our postgraduate training, we lack training about NIV in our residency days. So talking about optimizing NIV is in just in an hour is a huge task being given to me by Dr. D.P. Singh, sir. So what I did that yesterday, I talked to some of my postgraduate students to understand that what they expect from this 1 hour session on optimization of NIV. And everybody talked in unison. Everybody said to me in unison that they know the indications, but they find it very difficult to set an IV or to implement an IV in clinical practice. So my focus today would be to talk about the settings of an IV and how can make an IV comfortable or to how to make an IV synchronized with the patient in respiratory failure in ICU setting or home setting. To start with, let's understand what are the benefits of an IV. An IV is a mode of ventilation without an artificial airway. So we do not put any endotracheal tube. We do not put any kind of artificial airway device. So any complications related to artificial airway wouldn't occur with an IV. For example, if you put an if you keep the airway patent without any artificial airway, the patients would be able to speak well, would be able to eat, would be able to drink, would be able to talk. So this is a huge help on the patient's mental status when they are in the ICU. If you do not put any endotracheal tube, then healthcare associated pneumonia incidence is very less with an IV. Not only this, even if you use an IV in chronic respiratory failure, for example, if you are using the patients with chronic stable COPD, which is hypercapnic, and we give an IV during the night only. So even if we give nocturnal NIV to these kind of patients, there is huge benefit to them. How? Because if you give nocturnal NIV during the night, the NIV will offload the inspiratory muscle and the respiratory muscle fatigueness will improve over the period of a night. And in the day, they would have lesser work of breathing. NIV during the night might correct the microatelectasis, improving the forced vital capacity, and the patient's dyspnea will be less in the day. NIV helps decrease the nocturnal PaCO2. When the nocturnal PaCO2 is reduced, bicarbonate excretion increases, and the central chemoreceptor sensitivity to the PaCO2 is restored, and the patient has less daytime hypercapnia. So these are the huge benefits of NIV in compared to the other modes of ventilation. Let's have a basic understanding. How does an IV work? An IV gives pressure during the inspiration and the expiration. So breath is supported by pressure. When pressure is applied during expiration, what is going to happen? When we apply pressure during expiration, because the pressure in the airway is high, the lungs will not completely empty its air. So at the end of tidal breathing, there will be more air in the lung. That is called functional residual capacity. So once functional residual capacity is increased, shunt will decrease, VQ mismatch will improve, and hypoxia will improve. Second, it counteracts the auto PEEP. When you give the EPAP, it counteracts the auto PEEP. I would be talking about it. This is a very important concept in an IV. When we give the pressure during inspiration, that is IPAP, we talked about EPAP. Now I'm talking about IPAP. When we give pressure during inspiration, the pressure helps air to move in the lung. So the respiratory muscle load is decreased. And also NIV relaxes the diaphragm, which is the main inspiratory muscle. So overall, the load on the inspiratory muscle decreases and the work of breathing improves. Patient will feel less dyspneic and the tidal volume will improve. NIV also has positive cardiovascular effect. It decreases the LV preload, it decreases the LV afterload, improves the cardiac output, and hence NIV is of immense benefit in acute cardiogenic pulmonary edema. NIV decreases the PCO2 level. Once the tidal volume increases, minute ventilation increases, the PCO2 level goes down, and the hypercapnic induced encephalopathy improves. So NIV has a lot of benefits, and now we know that how the NIV is going to work for my patients. Now coming to a very important concept. I told you that in NIV, we give positive pressure both during inspiration and expiration. I also briefly mentioned that when we give the pressure during expiration, that is EPAP, or we also call it extrinsic PEEP, it counteracts the auto PEEP in acute exacerbation of COPD. Now, I believe this is a very important concept to understand during ventilation. Let's talk about auto PEEP. What is auto PEEP in COPD? In severe COPD, the elastic recoil of the lung is lost. We know that the expiration is a passive process. Expiration is helped by passive recoil, elastic recoil of the lung. Once elastic recoil of lung is decreased, the expiration is not very efficient, or exhalation is not very efficient. When the exhalation is not very efficient, so what will happen? At the end of expiration, more air will remain inside the alveoli. And this air will create or generate the pressure in the alveoli. So at the end of expiration, there is a pressure generated, positive pressure generated in the alveoli. And this is called auto PEEP. This occurs with severe COPD. In acute exacerbation, it increases. Now, how is it deleterious for the patient? If you have the auto PEEP, at the beginning of inspiration, patient will have to generate higher pressure because there is already a positive pressure in the alveoli. So to move the air in, at the beginning of inspiration, the patient will have to generate higher pressure. This is called threshold load. In order to generate higher pressure during inspiration, in the presence of auto PEEP, the muscles will have to work more. There will be excessive load in the inspiratory muscle. There will be respiratory muscle fatigueness and hypoventilation, hypercapnia. So when we give pressure during expiration, NIV, if the NIV is going to give pressure during expiration, that is called EPAP. This EPAP should be in an amount to negate the auto PEEP. So when you have a pressure applied during the expiration, you already have a pressure supplied by the machine. So that extra pressure required will not be burnt by the patient now, and hence the patient's work of breathing will improve. This is called counteracting of the auto PEEP. And this is a very important concept in an IV. I would request all of you to give a very, kind attention to every details that I'm talking about, because then only we can understand the NIV. There'll be a lot of physiological and machinery concept during my talk. And if you are going to pay a very kind attention to the details I'm talking about, you're really going to have a very good understanding of NIV application in ICU and the home setting. When should we consider NIV? The point is, if you want your NIV to be successful, you really have to be very selective. Your selection criteria should be very strict. You are going to choose only those patients who are suitable to receive an IV. If you are not going to do that, you are actually delaying the intubation in the patients who are actually requiring that. And delaying intubation has high mortality. So understand, be very, very strict in selecting your patients. Most of the patients who would require NIV in acute respiratory failure will be dyspneic, will be tachypnic, will use accessory muscles of breathing, may have paradoxical abdominal breathing, and they might have hypercapnic acidotic breathing. So these are usually the group of patients selected for the NIV. And if you select the patient for NIV and apply NIV, you have to closely monitor these patients in the first 24 hours. And I'm telling you, the first 2 hours of the NIV use is observation in the first 2 hours of the NIV use is very, very critical. Because if your patient respiratory rate, pH, PF ratio does not improve, then please do not keep going on NIV, because these patients might need intubation. And if you delay intubation, mortality is going to be high. So we really need to understand that in these first 2 hours, what we have to do with the patients with NIV. So this understanding will help you correct application of NIV so that you can increase the result of NIV in the first 2 hours, and your NIV failure will decrease, NIV success will improve. Based on that, there are certain indications and recommendations. And when I talk to my postgraduates before, before this session, they actually were worried to understand how we are going to set the NIV. So they were all like, they understand the indications, they understand the recommendations, and I have just 1 hour to talk about everything. So I would just omit these kind of things, indications and recommendations. You can have you have a plenty of literature to read about it. And I would request my delegates, my students, to read about it. It's not an easy kind of things. You have to pick up some very, very important thing when we discuss indications. So it is available in plenty in the literature. So kindly go through that. I'll just omit this. However, during the discussion, if anybody wants, I would address it. So if you have an indication and recommendations, and then you start NIV. Usually, the recommendations of NIV and indications in acute respiratory failure are the group of patients who have acute exacerbation of COPD, acute exacerbation of asthma, acute heart failure, post-extubation. And if you talk about chronic respiratory failure, the indications of NIV in chronic respiratory failure is COPD, pulmonary rehabilitation, obstructive sleep apnea, obesity, hypoventilation syndrome, neuromuscular disease. So these are the common indications in acute respiratory failure and chronic respiratory failure. But be very diligent to read about it, because you are going to get certain very important things out of it. Not every patient of COPD who will get in chronic respiratory failure will be suitable for NIV. Not every patient of OHS, obesity hypoventilation syndrome, will require kind of may require different kind of NIV. So be very diligent, study it in details, and I would omit these parts because I just have an hour to talk about it. So let's briefly discuss a bit about contraindications. Once you have a patient, once you have chosen a patient based on indication and recommendations for NIV, the first thing that you will look after that is the presence of contraindications. The only absolute contraindication is the patient who needs immediate intubation and invasive mechanical ventilation. If a patient's airway is unstable, you cannot use NIV. If the patient requires immediate intubation, then this becomes an absolute contraindications. Or other contraindications are relative. For example, if a patient has facial trauma or facial abnormalities, it becomes a relative contraindications. Because if in these kind of patients, you cannot use facial mask, but there is an option of helmet mask, or we call it helmet interface. I'd briefly discuss helmet interface because that is an important point to discuss. So if there is facial trauma or facial abnormalities, there is a choice to use helmet interface in those kind of patients. Please be very, it's not comfortable to use an IV in a patient who is hemodynamically unstable. If your patient is in shock, if your patient is having unstable cardiac rhythm, then those are the patients who are not suitable for an IV. In a patient who has recent bowel surgery or bowel obstructions, these are the patients in whom they are not going to tolerate positive pressure and IV ventilation. Patients who are unconscious. Now, in unconscious patients, it's a kind of choice by the physician. You will have to balance two things. Your patient might be unconscious because of hypercapnic encephalopathy. And as I told you with NIV, the unconsciousness improves because PCO2 level decreases and hypercapnic encephalopathy abolishes. So NIV helps. But if that unconscious patient is having copious airway secretions, then those are the patients who would not be able to hold his secretions well. And these are the patients in whom, despite having hypercapnic encephalopathy, using NIV will be dangerous, and you won't be able to succeed with NIV. So in this kind of situations, you have to be judicious. When we apply NIV, then we immediately look for the short-term complications. It's important because once you put the patient on an IV, you really need to look for the complications that may develop in the short term. That are the pressure source, skin irritation, mask discomfort. The patient might have dry mouth and nasal congestions. Because what happens during an IV, the nasal mucosa gets dry. A dried nasal mucosa will release the inflammatory mediators, and upper airway resistance will increase. When the upper airway resistance is increased, the patient's work of breathing or the patient will need high IPAP support, and that might make your patients uncomfortable. So this is the short-term complications that you have to look into. Gastric distensions. We do not increase IPAP IPAP above 30 centimeter of S2O. So your maximum IPAP limit is 30. That is the peak inspiratory pressure. This is just because to avoid, aerophagia or gastric distension. If your patient is having mask leak, then also the chance of developing gastric distension becomes high. And the patients who already have ZERD, if they are going to have a high pressure support, then those patients might also develop gastric distension and aspiration. Of course, we need to look for the pneumothorax in the short term, the first 24 hours. So let's talk about briefly what are the NIV devices we have. CPAP. In CPAP, we apply the same pressure during inspiration and expiration. So the pressure during inspiration and expiration remains same. CPAP basically delivers extrinsic PEEP. And just now we discussed what is extrinsic PEEP, how is it going to counteract auto PEEP. So if you have that concept in mind, you understand what CPAP is going to do. Bilevel NIV. In bilevel NIV, we apply different pressure during inspiration and expiration. So there will be a pressure during expiration. There will be a different pressure during inspiration. Because if you give the same pressure during inspiration and expiration, that is if IPAP and EPAP is same, then it becomes CPAP. So in BiPAP, we give a different IPAP and EPAP. And a BiPAP is usually a spontaneous mode of ventilation. What is a spontaneous mode of ventilation and how the BiPAP works? The BiPAP is triggered by a spontaneous effort of patient. How is it triggered? When the patient starts inspiration, the flow decreases. And this decrease in flow is sensed by the ventilator, and the inspiration starts or the ventilator is triggered. We call it triggering. So the ventilator is triggered by the spontaneous effort of the patient, which decreases the airflow. Now, this bilevel NIP or BiPAP is a pressure target ventilation. What is pressure target? So it is going to achieve the pressure that you apply, and that pressure will start the airflow. And it is cycled usually by the flow, sometimes by the time. So what is meant by the cycle? Because we will be discussing these kind of things again and again. Cycle means what brings or what changes inspiration into expiration. This is the cycle. So once the patient goes in inspiration, it is the flow. What happens during inspiration? Once the patient start inspiration, the airflow rapidly increase. That is, and reach to a maximum. We call it peak airflow. And then during inspiration, the pressure, the flow remains same, it plateaus. And during inspiration, thereafter, the flow starts decreasing. So flow rapidly increase, it achieves a peak flow, then flow remains plateau, and then flow starts decreasing. At a certain percentage of the peak flow, the machine cycles it into the expiration. So cycling in BiPAP is flow mediated cycling. And if you put a backup rate in BiPAP, it becomes a spontaneous time mode of ventilation. And I'll talk about when to have a backup rate in NIV, when to have ST mode of NIV. Another NIV is VAPS, volume assured pressure support. I won't be talking about it today. Another NIV mode is nasal high flow, and nasal NIV is non-invasive open ventilation. I won't be talking about it today also, and negative pressure. So what my focus today would be on bilevel NIV, that is BiPAP, and NIV ST mode. Now, let's understand a very basic thing which is going to help you a lot in your ICU. If your patient is receiving CPAP, for example, if you applied CPAP in a patient with acute cardiogenic pulmonary edema, that's fine. The mean airway pressure delivered by CPAP appears more effective when at high FiO2. So if a patient, for example, if his acute cardiogenic pulmonary edema is hypoxic, you are giving FiO2 to say at 60%, and a very small amount of CPAP pressure will improve hypoxia a lot. So CPAP seems to work very well. Contrary to that, on the flipper side of this, understand this, and this is a real clinical phenomenon which we all encounter. We need to understand this. CPAP doesn't seem to work well with higher FiO2 needs. Let's understand this. The first situation was where you gave the FiO2 and slight CPAP pressure improved a lot. The second situation is you are giving an FiO2 and even a very high CPAP pressure is not going to help your patient much. What does it mean? If you remember, the last class I had about arterial blood gas analysis, I talked about gas exchange. and I talked about shunt. In a patient with shunt, higher FiO2 is not going to improve alveolar arterial oxygen gradient. So shunt worsens. So if you are giving a high Fi2 and also adding a high CPAP and patient is not improving at all, then your patient might have underlying shunt. So be choosy and keep your mind open. Exclude ARDS, exclude pneumonia. So these are the things that you have to keep in mind when you use CPAP. Let's talk about what everybody wants to know. What everybody wrote to me, that everybody wants to know how to start patient on an IV. So this will be the crux of the talk. First, what are you going to do? You have selected your patients for an IV. You know what the contraindications are. Now you are going to use an IV. The first thing is optimize the patient's position. Patient should be in semi-recumbent position, somewhere between 30 to 45 degree. Semi-recumbent position is the position where you are going to use the NIV. There are certain exceptions. If your patient's belly is protuberant, for example, if patient is morbidly obese or your patient is pregnant, then lateral side position will work better. And during COVID pandemic or COVID crisis, we understood the prone positioning with an IV. So a patient with acute hypoxemic failure, if he's not responding well to the NIV, so you can position the patient in prone and see if there is improvement or not. But ideally, most of the patients will be in the semi-recumbent position. Once you have positioned the patient, now what you are going to do next? Next is choose the right interface. It's important. Now I'm going to tell you, if a patient is in acute respiratory failure, is in your ICU, the best mask is oronasal mask or facial mask. But if the patient is going to use NIV at home, the best interface is nasal mask to start with. Now, some of the patients may not tolerate oronasal mask. So for those patients, I'm going to talk briefly about another interface, which is very popular. So before I discuss that popular mask, I'm going to discuss a little bit about interface. This is an important point. When you choose the interface, the first was whether you are using it in acute situation or chronic situation. Acute oronasal, chronic nasal. In ICU setting, what type of ventilator you are using is also important while you choose the interface or mask. If you're giving an IV with critical care ventilator, then the interface should not have any entrainment valve and the interface should not have any leak port. This is important because in critical care ventilator, these are double limb circuit ventilator. The patient has exhalation port. But if you are using portable bilevel ventilator, then it is important to understand that mask must have entrainment valve and leak port. Why? Because the portable bilevel ventilator is a single tube circuit. It doesn't have a different exhalation valve mechanism. So if your mask is having an entrainment valve, what is it going to do? It's a single limb circuit. If the circuit gets disconnected for any reason, or your ventilator gets disconnected for any reason or starts, shuts down for any reason, if there is entrainment valve, the patient will have air through that entrainment valve and there'll be no asphyxia. In the single limb circuit, portable bilevel ventilator, it is also important to have a leak port, because that leak port will give intentional leak. When I say intentional leak, there must be some unintentional leak also. Intentional leak is must in single limb circuit portable bilevel ventilator. Why? If you have a leak port, it will allow the intentional leak. An intentional leak is useful because the patient has to, whatever CO2 the patient exhales, that has to come out, because otherwise the patient will rebreathe the CO2. And this does not happen with the critical care ventilator. So this is the intentional leak. And what is unintentional leak? Because this leak is must. Unintentional leak is something which is not desirable. Because leak can occur with the mouth, leak can occur with the poor fitting mask. So if there is leak which is not intentional, this is if the leak is because of the poor fitting of mask or the mouth leak, this becomes unintentional leak. And remember to check that unintentional leak should not exceed 25 to 30 liter per minute. If your unintentional leak is above 25 to 30 liter per minute, the patient is going to have asynchrony with the ventilator that I would be discussing. Let's talk briefly about helmet interface. Helmet interface, when the patient cannot use the oronasal mask or the nasal mask, helmet interface is something which patient accepts very well. It has a higher compliance. Higher compliance allows for even a lower continuous flow rate. So there is a term here, continuous flow rate. What is it? With any NIV, the patient receives continuous airflow. This continuous airflow is not only during inspiration, is not only during expiration, but this continuous airflow continues even during the pause, even between inspiration and expiration. So there is continuous airflow irrespective of whatever phase the patient is in, even if the patient has apnea. Why is it important to have continuous airflow? Continuous airflow will help CO2 wash out. If whatever CO2 the patient is exhaling, that continuous airflow will sweep that CO2 out. Continuous airflow is very important for the trigger of the ventilator. As I told you, the trigger in this ventilator is spontaneous. When the patient starts inspiration, patient takes some flow in. So there is decrease in the continuous airflow, and that is sensed by the ventilator to trigger the breathe. So continuous airflow is important. And helmet interface is a kind of interface which allows for even a lower continuous flow rate. Patient is comfortable. If the patient demand for the airflow is greater than the continuous flow, even then it doesn't cause any asynchrony. Since it is not tightly applied over the face and neck, so there are no pressure injuries and leaks. Leaks are very less common, and pressure injuries are very less common with the helmet interface. As I told you, continuous airflow helps remove CO2 and prevent CO2 rebreathe. So let's understand a very practical point here. If you are using a helmet interface, it's very difficult to use CPAP with the helmet interface, because CPAP has a fixed continuous airflow of around 30 liter per minute. But in helmet interface, if the continuous airflow goes below 40 liter per minute, then CO2 washout is not effective and CO2 rebreathing will occur. So it is important that if you are using helmet interface, please do not use CPAP. Another very important point. Helmet interface should be used only in hypoxic respiratory failure. Do not use helmet interface in hypercapnic respiratory failure. Because helmet interface improve hypoxia well, but with the helmet interface, because the patient has a larger dead space, if the dead space is large, minute ventilation will be less, and patients, the machine will have to give a high pressure, and this high pressure with low continuous flow rate, it's a problematic. Patient might have CO2 rebreathe and hypercapnia may worsen. So it is important. If you are using helmet interface, use it only in acute hypoxic failure, not in hypercapnic respiratory failure. So when you use an interface, wrong size of mask, incorrect positioning, insufficient mask seal may all lead to NIV failure. So this is why there has been an interface algorithm, and this is really easy to understand. There is nothing difficult in it. If your patient is in acute respiratory failure, oronasal mask. If your patient is in chronic respiratory failure, nasal mask. When you apply interface, check for the leaks. There should not be unintentional leak, because if there is unintentional leak, NIV will fail. An unintentional leak, as I said, should not exceed 25 to 30 liter per minute. Check for the asynchrony. Check for the ventilator setting. What ventilator setting you have? Is it a critical care ventilator? Because then you don't need any ports. If you give the port, it will be inefficient. If there is a portable ventilator, there has to be port. If there is no port, there'll be asynchrony. And look, if the patient is adapted to NIV, it's good. Look for the immediate complications and all. But if the patient is still not adapted to NIV, go and recheck the interface again. And at the same time, is your patient still suitable for NIV? If your patient is still suitable for NIV, you have went and rechecked everything is fine, but still patient is not tolerating the interface, change the interface. This is very simple algorithm, and this is very important for the NIV success. How to set up an NIV? What are you going to do? You have selected the patients for NIV. Once you have selected the patients for NIV, what you have done, you have selected the interface. Now, you have selected the interface, you have selected the patient. What are you going to do now? Turn on the ventilator and humidifier. Once you turn on the ventilator and humidifier, there is a leak test in that. Press the button for the leak test and see if intentional leak is working well or not. So, ventilator is on, humidifier is on. Now, what will you do? Will you put the interface over the patient and then connect the circuit, or will you connect the interface with the circuit first? So what will you do? It is important. You have positioned the patient, you have selected the interface. Now your NIV is on. Connect the interface first to the circuit, not first to the patient. And once you have connected the interface to the circuit, talk to your patient briefly. What are you going to do with it? Why is it important for patients to have it? If you are not having a brief dialogue at that time and directly put it over the face, most of the patients are not going to tolerate it. It's a positive pressure ventilation. Patient is not sedated. So it's important. So once you have explained the patient, is it enough? No. Patient agreement is must. So once you have connected the interface to the tube or circuit, then you put the interface over the patient's face. Not tight it, not entrap it. Just apply it over the face. And so that if the patient finds it difficult, you can immediately take it out and talk to your patient. Because if you are going to stop it suddenly, the patient will be restless, agitated, and he will refuse taking it. So just put it over the patient's face, talk to the patient. If everything is fine, then stack it. Once you have done it, now your ventilator is on, your patient's interface is on patient's face, interface is connected with the ventilator with the tube. How are you going to adjust the settings? What are you going to do now? So the first step is set EPAP. The first task is set EPAP, not IPAP. First is EPAP. The initial EPAP should be 4 to 6 centimeter H2O. I keep it around 5. And increase the EPAP every 1 to 2 minutes to achieve consistent triggering. Now, this is important concept. If you put an EPAP, how are you going to titrate the EPAP? EPAP, a sufficient EPAP means every patient's every effort should trigger the ventilator. So if it's not happening, keep increasing the EPAP to a maximum of 8 to 12 centimeter H2O. I go maximum till 10. So keep increasing the EPAP till every effort of the patient trigger the ventilator. So how is it going to trigger? Why? How is it going to, what is the relation between this? If you understand this, this becomes very easy. A patient with narrowed airway, what will happen? If the patient will take any effort, that effort will be dampened by the narrowed airway and will not be sensed by the ventilator. If you apply an EPAP, the airway starts open and every effort is transmitted well to the ventilator and sensed very well by the ventilator. So EPAP titration should be consistent triggering. Now there is an important step I'm going to tell you now. This we need to understand. If you have increased EPAP to 10 and still patient's every effort is not triggering the ventilator, what would you do? You would adjust the trigger sensitivity by adjusting flow trigger. Now, briefly about this, not a difficult concept. Trigger sensitivity or flow trigger, what is it? As you all know by this time, that the flow triggers the ventilator. The change in airflow that is required to trigger the ventilator is the flow trigger. So if the change in airflow required to trigger ventilator is less, then it means the ventilator is trigger sensitive. So what will you do? If your EPAP maximum 10 EPAP is still not triggering your ventilator, you will increase the trigger sensitivity of the ventilator. And how will you increase the trigger sensitivity of the ventilator? Keeping the flow trigger less. Less flow trigger means less amount of airflow will trigger the ventilator. So you give the EPAP of 10, patient still not having consistent triggering. So you will have to lower down the flow trigger. And there is setting in every machine of this flow trigger. Just you have to put the button on the trigger and set it low. Second step. The second step is IPAP. Then you start the IPAP. You should start the IPAP of 8 to 12 centimeter S2. I start with 12 centimeter S2, and you up titrate it every 1 to 2 minutes. And your target should be tidal volume and respiratory rate. So up titrate the IPAP till you achieve the target tidal volume and target respiratory rate. Target tidal volume should be 6 to 8 ml per kg of ideal body weight, not the actual body weight. An ideal body weight, you can calculate, put your patient's, height and sex in the calculator, and it will give you the ideal body weight. And the target respiratory rate should be 12 to 16 breaths per minute. So you keep on increasing the IPAP till these two targets are met. And as I told you, the maximum IPAP that you can go is 30 centimeter S2O. And I'm telling you, don't be afraid in increasing the IPAP, because high intensity NIV, where IPAP up to 28, 29 has been found to be very successful in treating most of the acute hypercapnic respiratory failure. So once you have done it, let's understand backup rate. So you have certain EPAP, you have certain IPAP. Now look whether backup rate is needed or not. Backup rate is important in hypercapnic respiratory failure. Backup rate is not important in hypoxic respiratory failure. Why? Because in hypercapnic respiratory failure, hypercapnia abolishes the sensitivity of the central chemoreceptors, and there is respiratory depression leading to lower respiratory rate, or sometimes the patient might have a brief episodes of apnea. So you need to set up backup rate, because in hypercapnic respiratory failure, if the respiratory rate goes down and goes below the backup rate, then machine itself will deliver the breath. So this is important. If your patient is acute hypercapnic respiratory failure, set the backup rate. Acute hypoxemic respiratory failure, don't worry about it. And backup rate should be 4 to 6 breaths lesser than the patient's spontaneous breath rate. Third step. So you have certain EPAP, you have certain IPAP, and you have decided whether the backup rate is needed or not. Now, with the adequate EPAP, because EPAP is triggering, consistent triggering, adequate IPAP, because IPAP is delivering adequate tidal volume, IPAP is delivering, has corrected the respiratory rate. If the patient with adequate EPAP and IPAP fails to maintain saturation to a minimum desired goal, your goal will be different in COPD, in asthma, and restrictive lung disease. If the saturation is not still being maintained, now I'm coming to the oxygenation, then adjust FiO. This is the third step, and it is very simple. Last step, where we all, have a very scarce literature. We don't have much access to all the finer points. So last step in the ventilator setting. And this last step is important to maximize the patient device synchrony. You have set everything, but if your patient is not synchronized with the device, your NIV is going to fail. What does synchrony means? Synchrony means the patient's neurogenic inspiratory time and expiratory time is consistent with machine's mechanical inspiratory time and expiratory time. So when the patient is in inspiration, the ventilator should be in inspiration. When the patient is in expiration, ventilation should be in expiration. This synchrony should be maintained. And how will you maintain this synchrony is what final step we'll be talking about. To maintain the synchrony, we need to adjust few things. And those are inspiratory trigger sensitivity, flow trigger. Just I talked about flow trigger. Second, expiratory trigger sensitivity, ETS, cycle sensitivity. This is really, really important. Third is inspiratory time and TI max. And last is P ramp or rise time. Sanjay sir, or Dr. If like, if it's okay with all of you, I can go with this final step and we'll discuss about it. Sanjay sir, should I talk about this now? Sir, you are mute. Sanjay sir, should I talk about this now? Sir, please unmute yourself. Sir, unmute yourself. Please unmute yourself. Okay. I guess I should. So let's talk about final step. In final step, the first thing will be the flow trigger. What is flow trigger? Just I talked about the change in the amount of flow that would trigger a breath.
Madhukar, I was not allowed to unmute. Now I am allowed to unmute. So
Should I go ahead with this final setting today, or like as you say, like
how much time do you need more?
I guess 15 minutes.
I think if you summarize in a better way, because it is too long, and the students may get overburdened with a lot of terminology and the complexity.
Yes. So this is why I guess that these final steps of patient ventilator synchrony, I should keep it in the next class, because that would help the all the postgraduate students to understand, because they will come with a clear mind. So what we talked about when NIV is needed. We talked about if you have selected NIV, what interface you should select. First, you position the patient, you select an interface, then you connect the interface to the tube, then you keep it over the patient's mouth, talk to the patient, make an agreement, apply it, and to start the NIV, to titrate the NIV, the first thing you set is EPAP. EPAP target is consistent triggering, not the FiO2. After EPAP setting, if your consistent triggering is not achieved even with EPAP, adequate EPAP, then what you do? You increase the trigger sensitivity of machine by decreasing the flow trigger. And then you start titrating the IPAP. For the IPAP titration, your target is tidal volume and respiratory rate. Once you target tidal volume and respiratory rate is achieved, then you think about the backup rate. Patient is hypercapnic, apply a backup rate. Hypoxic, don't worry about it. And once you have set the IPAP in EPAP, look for the oxygenation. Even with adequate EPAP and IPAP, oxygenation is not optimal. Increase the FiO2. And finally, you want your patient to be in synchrony with the ventilator. Patient should not fight with the ventilator. So this synchrony maintenance is really important. Even if you have set everything right, your NIV may fail because patient is not in synchrony with the NIV. So I will talk about NIV patient synchrony and asynchrony in part 2 of the NIV. when we'll have the next class of the NIV. Thank you so much, Sanjay sir. Thank you so much, Dr. DP Singh sir. Can we take the questions now?
So, so it was a very nice lecture about the NIV. One and two things that I would like to summarize the whole things. The success of NIV not only lies in knowing its benefits, but also knowing its limitations. So, as Madhukar has explained at the very onset, that you must be knowing the contraindication and when to stop the NIV and to move to the other mode of ventilation, that is the invasive ventilation. So, in the way, initially, it is a very labor-intensive procedure. So, it is not like that you put the NIV and you forget it. So, you will have to put the NIV in a very, very guarded manner. As he has explained, don't tie the mask immediately. First, put the mask on the face, and then let the patient feel it and start triggering the inspiration. Then you should try to tie it up. And once it is being tied it out, you will have to look in the first 2 hours whether the patient is getting appropriate benefit or not. Because when you will have to stop it and you will have to switch to the another mode of ventilation is very important. So it is very important. So 2 or 3 things that we must be knowing very nicely about the trigger, about the cycling, and how to choose the interface. It is also again very important, and he has explained very nicely how to choose the interface. There are templates also that fits as per the face size. So these are the points where we falter and we find that the NIV is not working and NIV is not successful. So these are the points that we fail sometimes. So we must be very much aware. There are few questions also. Madhukar, you can open the chat and you can see the questions.
Okay, sir. Okay. So before I see the question, I'm going to tell you that what we are going to have in the next class, we will talk about the last step of setting so that patient synchrony with the machine can be established.
Yes.
We will talk
Yes.
about NIV failure that Dr. Sanjay sir was just talking about, when we will understand that your NIV has failed. And finally, we'll talk about patient ventilator asynchrony. So this I will take in the next class.
And Madhukar also add, once you put the NIV, how to monitor it. That
Yes,
is
sir.
also very important.
Yes, sir.
That is very important.
Yes. When I will talk about NIV failure, I will talk about the monitoring, because that monitoring will decide the failure of the NIV.
Yeah.
So
Yes. Yes.
yes, I have the questions. Like just questions in the chat. There is chat box. So there is one question by Dr. Neha Kumari. Role of NIV in prevention of post-operative respiratory complications. Yes.
Yes. Yes.
Post-operative atelectasis. Post-operative atelectasis is an established indication for NIV, and it is an acute hypoxemic respiratory failure. So when you are going to apply NIV in post-operative atelectasis, be sure that your NIV should have the setting for the restrictive lung disease. And this will be more clear to you when I'll talk about, settings in the final step that I have skipped today. The another question. Sir, can you take the question? Cursor is not
Madhukar.
moving now.
Yeah. The Madhukar, the another question is about the high pressure IPAP, that is more than 30 or not. So I think you keep it for the next class, and it would be better if we explain them why initially in the older models of the machines the highest pressure was only 20.
Yes.
Now the new generation of the machines have higher pressures.
Can I explain it now, sir? Because
Yeah, yes.
we have sufficient evidence to suggest that high intensity NIB works more efficiently to improve the hypercapnic respiratory failure. Initially, when we had the IPAP setting of 20, we had the high NIB failure. With the IPAP setting moving towards 30, we are having lesser and lesser NIV failure. And I'm telling you, we had a very famous trial which suggested that if you use a high intensity NIV, if you can take your IPAP up to 28 or 30, you remember the hot MF trial, where most of the patient received IPAP at 28 with EPAP of 4, and they were very successful. They reduced mortality by 17%. So high intensity IPAP, as I told you, do not be hesitant to take your IPAP as to the upper limit as you can. Don't worry about it. But maximum peak pressure should be 30. You don't try to go beyond that, because if you are going beyond that, your patient is not going to tolerate it. And then there'll be asynchrony and the patient will be very intolerant, and you won't be able to use an IV in them.
Very nice, very nice. And one thing that I would also like to add, that if you give very high pressure, that is more than 30 or something like that, there are every chance that that it will exceed the lower esophageal pressure. And there may be, as you have told, that the patient may not be tolerating high pressure, and there may be some air going into the abdomen, and there may be the abdominal blotting and all that can lead to further jeopardize the respiration. So these are the certain problems that we may face at a very high pressure. So it has been subjected to a maximum of 30 mm of water.
Yes. Sir, I can see a question regarding this from Deepak. It has just come out. If some patient of OSA and hypercapnic respiratory failure, and it will need IPAP of more than 30 to control the symptom, you said we should not use above 30. What to do, sir? Intubate the patient or simply put Ryle's tube and continue BAPAP? So, Deepak, it's an important question.
Very good, very good, very good.
Let me tell you, yeah, a lot of patients of OSA will have hypercapnic COPD. A lot of patients with OSA will have hypercapnic hypoventilations, obesity hypoventilation syndrome. So a hypercapnic respiratory failure with obstructive sleep apnea. If your patient of obstructive sleep apnea has hypercapnic respiratory failure with COPD, and you have moved the IPAP to 30, and you are not going to decrease the PCO2 level, what are you going to do? I'm going to talk about in the next session very well about it. So what you're going to do is you need to increase the trigger sensitivity of the BiPAP device. How will you increase the trigger sensitivity? By decreasing the flow trigger. And this concept you will understand when I will talk about this in the next class about the final NIV setting. The second group of patients who have OSA and obesity hypoventilation syndrome, and they are hypercapnic. So when the patient has OSA with hypercapnic, obesity hypoventilation syndrome, your choice is CPAP. And if the patient is not able to tolerate CPAP, you have used the CPAP and the patient has not tolerated it, then you will go for the BiPAP. And even with the BiPAP, with IPAP pressure of 30, you are not able to reduce the hypercapnia, then these are the patients who are suitable for targeted volume pressure support. So we call it AVAPS, volume assured pressure support ventilation. What does it do? This volume assured pressure support ventilation or VAPS will give selected tidal volume. You're assuring a tidal volume. So once you have assured a tidal volume, hypercapnia is going to abolish because you have assured the tidal volume. Machine has to automatically set the pressure and pressure support because you are giving the EPAP. So they are the two different situations and you have a two different answer for that. Thank you, Dr. Deepak.
Thank you, Madhukar, for very nice lecture and the nice explanations. So we look forward for in the next class for the other things. So at that juncture, I would like to finish the class. So thank you again. Good night to all.
Yeah, thank you so much, sir. Thank you so much. Looking forward for the next class. Good night, everyone.